Right. And uh, let's change pointer. Right. And are the slides moving now?
Yes, sir.
Yes, sir.
Right. So can I start now? Right.
Yes, sir.
Yeah, good evening, everyone. So today I'll be discussing approach to pancytopenia, and my emphasis is on non-neoplastic disorders. Uh, Many times in pathology per se, neoplasias contribute a lot of time and effort and space, but this part is sometimes slightly neglected, and it's important to deal with certain diseases, non-neoplastic diseases causing aplastic anemia. So we'll go sort of case wise. I'll show certain cases, ask some simple questions, and if there's theory, I'll try and just brush through the theory part. It's more emphasis on morphology per se and how you go about diagnosing the disease. This is all the material from my institute, so that's just a little disclaimer there. Cytopenias per se could be unilineage when it's, say, only isolated anemia or isolated thrombocytopenia or isolated leukopenia. It could be combinations of two, or it could be a trilineage, which is the topic of today, this pancytopenia, where you find reduction in all three major formed elements of blood below their normal limits. So we need to know the normal limits, right? So that's from WHO, where anemia is defined below 13 grams per deciliter in non-pregnant female, below 12 grams, leukopenia below 4,000 cells per microliter, and thrombocytopenia below 1.5 lakhs per microliter. So that's the basic definition of pancytopenia when all the three lineages, major lineages of in the blood are decreased below their normal limit. So with this, I think I can start cases directly. Okay. So we'll just see that important thing is pancytopenia is not itself a disease entity. It's not a diagnosis. You are looking for a diagnosis when a patient comes with pancytopenia. The other important thing is, besides the cause or etiology, the other important thing for management is the severity. So there are two things which clinicians will definitely want to know: what is the cause of pancytopenia and what is the severity, because that may have implications for the patient. So we start with the case. The first case is a child, 8-year-old male child, presented with easy fatigability for 2 months, history of 2 units packed RBC transfusions, and on examination, the patient had pallor and no organomegalies. The complete blood count showed hemoglobin of 8.7 grams per deciliter, TLC of 3.28, and platelets of 22,000. So there's a pancytopenia there. Uh, the peripheral blood, I'll probably, in low parts, I'll probably not ask too much to the students there. I might describe myself. And high power, let's see if things are more clear. So here you could see that RBCs, there's a little lower density of usual, and the RBCs don't look too much, isopoikilocytic. There are some leukocytes there, and obviously decreased at 20x. There are just two of them seen there. I'll go in the hyper. So here, probably Janvi can come in. If there's a cell focused in the center, it's looking like what cell? Am I audible?
Yes, sir.
Right, Janvi. So if you can see, there is one WBC in the center, and then there you just uh, can tell me what kind of cell you are looking into in the peripheral blood. Is it a neutrophil, a lymphocyte, a monocyte, a eosinophil? What cell you think it is?
So it's a lymphocyte.
It's a lymphocyte. It's rather, yeah, okay. So it's a mature looking small lymphocyte, possibly non-reactive looking. And usually the diameter of such nucleus is around 8 microns. So you can actually compare the RBCs with such naive, unreactive, non-transformed lymphocyte, a mature, naive-looking small lymphocyte. And you see that most of the RBCs are around 7 to 8 microns, looking good. The density is low, so there is anemia. And the platelets in the background are also just 3 or 4, so which means there is likely a thrombocytopenia on smear also, right? Um, the differentials here yielded 94 lymphocytes, so there was absolute neutropenia, right? And obviously, the cells in this low TLC were most of them were lymphocytes in the peripheral smear. We move forward. And so, if I've already described the RBCs, they were more or less looking normal, predominantly normal. The platelets are markedly reduced. I also give you an input that the reticulocytes are 0.1%, so which means they are reduced, right? So with that, background, there's a pancytopenia. There are lymphocytes predominantly with low TLC in the background, and you have a young child with history of transfusion, no organomegaly. What next, Pushpanjali? What next will you like to sort of do as far as workup is concerned? Pushpanjali, can you come in? Okay, anyone? Right. So I'll probably go for a bone marrow in this situation because I'll need to know whether the bone marrow is producing cells, it's hypercellular or normocellular or less cellular, and what all is happening in bone marrow in this situation when the blood is showing complete pancytopenia. Okay, there is an answer showing iron studies. Uh, Iron usually causes isolated anemia. It's unlikely to cause leukopenia, and it is fairly unlikely to cause thrombocytopenia, right? Because generally you will find thrombocytosis with iron deficiency. That's the usual association of iron deficiency. So it's generally a pure iron deficiency anemia, isolated anemia. Pancytopenia is quite unlikely, although iron deficiency per se is not uncommon, right? So next we go for a bone marrow examination. This is bone marrow aspirate smear. You see two small tiny particles there which look quite empty. They are hypocellular. I believe most of the students are exposed to some bone marrow examination there, although majority are first year and some might not have been posted to hematology at all. But I can go to some more basic levels before jumping into more. So you see another particle. This one again looks mostly composed of adipose tissue. There's some dark areas where the hematopoietic cells might be there, but mostly it is empty. At 8 years, that should be the condition of a particle, which should be absolutely packed, nearly 100% cellularity, nearly no or nearly absence of any adipose tissue seen. So if you compare from this particle, which is normal for 8 years, this one has a lot of adipose tissue and very scanty cellularity there. If you see the trails in the smear, they also look quite empty and lack of any hematopoietic cells. So in the next, I'll probably focus into areas where some cells are seen. This is also the particle on high power. You see just adipose tissue and their nucleus, small nucleus. There are some probably capillaries there and mostly empty, hardly any hematopoietic cells. So that focus in this marrow showed some cells. So these are some neutrophils there, lymphocytes, a nice looking plasma cell with some vacuoles. I go on high power. Somebody can come in, maybe somebody from 30, Lakshinder. Can you come in? Is Lakshinder around? Okay. Bhagyashri? Right, Bhagyashri is not there. Or okay, so we go back to Jahnavi. Jahnavi, are you around?
Yes, sir.
Right. So if this is slightly 20x, so you might be able to identify some cells. You see those dark, absolutely dark cells there,
Lymphocyte.
and maybe this one, and maybe this one, which is more spindled appearing. They are same cells. Can you sort of guess? Lymphocytes are here. Those are lymphocytes, small cells, the size of RBCs there. Lymphocyte, 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 lymphocyte. This is somewhat larger. You cannot see nuclear details. It's all dark granules, absolutely dark granules. Anyone?
Can't.
Little
There is
mast cells. These are mast cells actually. So you see, in the same field at 20x, you are seeing three mast cells there. Some of them are nicely rounded. Occasional one is little spindled. You also see many lymphocytes actually, a histiocyte there and a plasma cell. There are hardly any granulocytic series cells in this focus. There are also hardly any erythroid cells. So basically, very hypocellular kind of smear with presence of some mast cells, lymphocytes, histiocytes, and plasma cells. If I go on the next field also, there are histiocytes here with so odd-looking kidney-shaped oval nucleus, histiocytes, tailing cytoplasm. Again, histiocytes, some lymphocytes around. I can go on hyper, and you can see a large histiocyte there with fuzzy cytoplasmic borders there, large cell, a lymphocyte, some more lymphocytes, a smudge cell, mast cell in the inset there, nucleus in the center, and literally the boundaries cannot be seen. There are a lot of dark granules, a plasma cell with a little pale Golgi zonal area and a dark blue cytoplasm there. The particle which is totally hypocellular in the counts. You see, the myeloid cells are completely reduced. There are just two neutrophils, one metamyelo, one myelo. The predominant cell population is lymphocytes. There are 8% plasma cells. Erythroids are also reduced. So overall, there is pancytopenia with markedly hypocellular bone marrow aspirate, and they are just predominance of remaining cell lymphocytes and plasma cells. There's hardly any erythroids and myeloid component, and even megakaryocytes. So most of the important cells which are short-lived in marrow are gone. Only the cells which are long-lived, possibly lymphocytes, plasma cells, some histiocytes, some mast cells, they are retained and they still continue to live. Whereas the high turnover cells have all gone, they are all missing. Right? So at this time, we look into, so if you look together, you're probably dealing with a marrow which is with this celerity is completely gone, and we are towards a diagnosis with all we have in the clinical context, no organomegaly, pancytopenia, marrow which is looking empty. You're dealing possibly with aplastic anemia. Trephine biopsy definitely is important because it gives you confirmation of overall picture. Aspirate may sometimes yield a hotspot, some cellular areas, some variable areas. A trephine biopsy is definite. And so we go along trephine biopsy. These are two cores at low power, 2x. And again, you see only fat spaces. There's some hemorrhage, red cells there. They're just adipose tissue as compared to a trephine biopsy of an 8-year-old child, a normal child. That's the index case we are talking about. That's a normal control around 8 years of age. And you see just a few fat spaces, these empty areas. Rest of the entire bone marrow space is full of normal hematopoietic elements. So at this age, that should be a low power look of a normal bone marrow trephine biopsy. This one has just literally no hematopoietic cells, which means this is a biopsy, which is we are going towards a diagnosis of aplastic anemia. If I have to tell how normal bone marrow looks like over the age, then remember the bone marrow cellularity decreases with age, and there is apparently a formula we many times used to assess the bone marrow cellularity. But remember, many of the long bones, like the light green, which is the long bones, tibia, fibula, the cellularity there reduces very fast over the age. Whereas the flat bones, skull and vertebra, and the iliac bone from bone marrow or sternum with bone marrow is most likely done, retain the cellularity much longer. So, but on an average, when we assess a sternal or an iliac bone marrow taken from these spaces, there's a formula. Anyone? Pushpanjali, do you know how you assess with the age?
100 minus age. 100
Right, right, 100 minus 8. So if it's 20 years person, then 100 minus 20, there must be around 80% hematopoietic cells and 20% fat. So for a child of 8 years, there must be around 90%. hematopoietic cells and just 10% fat, right? So in this situation, you see there is hardly 5% hematopoietic cells or even less. There is nearly 100% fat, right? So yes, remember the formula is not very accurate. It just gives you an idea how cellularity would look like at that age. So I go on hyper. You see that there are some dark cells there, and we can't really appreciate which kind of cells these are distributed. There are likely to be some hematopoietic cells there amongst the adipose cells. I'm on the 100x now, and now you can say that there are some plasma cells, eccentric nucleus, amphiphilic cytoplasm, maybe some erythroid cells with dark nucleus, right? And maybe some other plasma cells also, and some RBCs there. So basically, there are no myeloid cells, there are no megakaryocytes, there are some lymphocytes and plasma cells, and some erythroid distributed erythroid cells. Here also you see 2, 3 plasma cells there, eccentric cells. So that's on 100x. So in all, you have a pancytopenia, empty aspirate particles, an empty bone marrow trephine biopsy. What is this? Anyone? Arpan? What is this stain? Blue stain in the particle? Anyone can answer?
I think Paul stain.
Right, it is pearl stain, right? So that stains iron in the particle, and this patient had loads of iron. It's probably going to 5 plus, maybe even 6 plus. So that's a heavy iron overload, and the possibility why the iron was high is because this patient might have been given some hematinics to restore counts, and obviously there is history of at least 2 blood transfusions, and that increases the iron over time, right? So there's an iron overload, which is very commonly seen in patients of aplastic anemia, especially who have been treated with transfusions, multiple pattern red blood cell transfusions. So that's the look of the particle loaded with iron. This iron mostly is lying inside the histiocytes, which are inside the particles. Sometimes you are able to see the dendrites, nice dendrites of histiocytes stained blue, where the iron is filling it. Right. So we have iron overload. That's the pearl stain, and pearl says 5 plus in its grading. So we have a diagnosis of aplastic anemia in this case. Any differential diagnosis? It's very unlikely, with this overall scenario, clinical picture, the counts and the bone marrow. But remember, sometimes you see some other diagnosis. I'll give you example of this. This was a 38-year-old male presented again with pancytopenia. The particles for 38 years still, they are not as bad as that child, but still are hypocellular. The marrow definitely is hypocellular. There's probably 80%, 85%, or even 90% fats there in all 4 cores. And the cellularity in the aspirate shows some cells. Some of these are lymphocytes. I can go on hyper. I can go on more hyper. So this is nice looking lymphocyte, dark chromatin, size of RBC nearly. But these are cells which are probably, you can fit in 3 or 4 lymphocytes in the diameter. So 1, 2, 3, 4, 3 to 4 times or 5 times the size of a mature lymphocyte. So that's the size of these cells. The chromatin is much lighter, paler. There's some scanty blue cytoplasm. So they are actually immature blasts there, right? So at that hypocellular marrow, if I'm seeing blasts, 1, 2, 3, 4, some granular blasts there, otherwise mostly agranular. There's some granules seen here. So that's the lymphocyte in picture for comparison. In the Trephine biopsy, it was quite hypocellular. In hyper, the dark cells here are likely to be lymphocytes, the small dark cells here, and you can compare these cells which have opened up chromatin, vesicular chromatin, and they're looking larger and immature. So there are clusters of these larger cells in between. You can see some small dark cells which are likely to be lymphocytes, or if they were darker, I could say even erythroid precursors. But you can see the larger cells. So in the intervening cells are mostly composed of immature cells in the aspirate also. And this might be a hypoplastic MDS or a hypoplastic AML. So you'll sometimes need to look into the cells carefully, whether they are mature lymphocytes or you're seeing some odd atypical cells before you actually give a diagnosis of aplastic. These are rare diagnoses. Probably you have diagnosed hypoplastic AMLs twice and a rare hypoplastic MDS. So that depends. You can stain this with an IHC of say CD34 or TDT or 117 and say that these are definitely immature cells. I don't have the IHC photograph for now for this patient, but So these are DDs. So you need to look these cells closely before you suddenly jump into diagnosis of aplastic. Although the diagnosis of a hypoplastic AML and hypoplastic MDS is very rare, right? But need to be cautious about that. So once you have aplastic anemia like pancytopenia, you need to go into the etiology of aplastic anemia and you need to tell the severity of aplastic anemia. Both of these are important for the management of the patient. So if I go into the severity, severe aplastic anemia is characterized by less than 30% cellularity. Two of these three, the neutrophil count less than 500 per microliter, reticulocyte count of 60,000 per microliter, less than 60,000, and platelet count less than 20,000 per microliter. So any two of these, and if it is not fitting into this, it's probably a moderate aplastic anemia. So that has consequences because the more the severity, the patients do worse when the treatment is given. There's a category of very severe aplastic also where the neutrophil counts go below 200, right? So there the chances of infection and other things and recovery become even more difficult, right? So that's how the severity of aplastic anemia is classified, and you need to provide that information to the clinician, definitely. So we have an entity of pancytopenia, which is the bone marrow failure, right? And if I go into details, it could be inherited bone marrow failures or it could be acquired. Acquired could be the usual idiopathic, which is immune related, or you might have some drugs or something else which is causing hypocellularity there. So this will run through this. Obviously, exposure to radiation, especially at higher doses, can lead into pancytopenia within 2 to 4 weeks of exposure. And you can have certain drugs, some analgesics, some anticonvulsants, antibiotics. This is not a comprehensive list. I'm just giving some examples there. And you have cytotoxic drugs, alkylating agents, antimetabolites, and some antimitotic drugs, which can cause hypocellularity of bone marrow. There are some heavy metals, some toxins like benzene, again causing aplastic anemia. Some viruses, EBVs, herpes group of viruses, HIV, some seronegative, so hepatitis A virus, B virus, C, so seronegative ones, some of them are known to cause uh, bone marrow hypocellularity. So these are causes, beyond the immune idiopathic types, which you need to rule out. The immune cause, of course, most of the severe aplastics are commonly immune types, if not inherited. And the most common cause attributed is the action of cytotoxic T cells. They have some problems there, which are known. They are either functionally abnormal and they secrete certain cytokines which have the effect on bone marrow cellularity. They have influences over cell by causing cell death using Fas ligand pathways, and there might be clonality or even oligoclonality with STAT3 pathways involved, mutations involved. We do run flow for lymphocytes in aplastic anemia, and we do see clonality in CD8 cells, a proportion of subset of CD8 cells which are effector or late cells. Many times you can see that very often even in idiopathic or immune type of aplastic anemia. That's also known, right? So I'm just running through that part because we'll spend more time on morphology and other things. Inherited, the common ones, Fanconi, dyskeratosis congenita, diamond black fan, Schwarzman diamond. The rare ones, GATA2 deficiencies, SMAD, MECON1, and there are genes involved. So I can possibly, yeah. So that's an important test for inherited. It's a sort of a primitive test for today's time of NGS, but it helps at times. So there's basically a clastrogen which is known to cause chromatin breakages and odd radial arrangements of the chromosomes. And one of these is diapoxybutane, other is mitomycin. You can also induce these breakages by exposing your lymphocyte cultured cells to blood to the radiations, right? So all of these can cause breakages. And in normal individuals, there is a mechanism to prevent these breakages, and they sort of, if the mechanism is intact, the DNA repairs and the chromatin will be normalized. So you see very few breakages after exposure to clastrogens. Whereas in case of Fanconi or in case of dyskeratosis congenita and these, you'll start seeing these radial structures. If you see more, you see those breakage there in the chromatin and those odd radial structures on the exposure of clastrogen like DEB. So that's it might miss sometimes these disorders, but it's sort of a test which can catch cases, and it's easier. It's not tough. Only thing is it requires a dedicated lab and a dedicated person to perform these tests, right? And of course, I leave this, the Fanconi genes, there are around 22 genes, out of which some are commonly involved in Fanconi anemia. Dyskeratosis congenita, most common dyskerrin, sorry, which is involved. But the theory you can read. Okay, so these are the FANC-A, FANC-C, and FANC-G are the most commonly involved in Fanconi anemia. And if you have to really go into diagnosing which kind of mutation and genes are involved, you have to do a targeted NGS panel for inherited bone marrow failure syndrome. These days, when an aplastic anemia is diagnosed, probably you have to categorize whether it's idiopathic or it is inherited. It has implications, and Rishi might later talk about, Dr. Rishi may talk about a little bit of this later. But it has management implications, it has clinical implications there. So if you have a targeted panel of genes involving the common or even the rarer, bone marrow failure syndromes, you probably can catch. Majority of these, some may still might be left. Okay, and there's something else before I quit aplastic anemia, that is PNH. So I need to probably spend around a minute or two, because that's also, it's rare but an important disorder associated very often with aplastic anemia. Rather, when we diagnose aplastic anemia on bone marrow, we screen for PNH in all cases, right? And especially in young adults, the percentage might go above 30-40%. The literature has a range, of diagnosing PNH in lower clones, in lower percentage of cells in aplastic anemias from say 15-20% to even 70%, which may occur simultaneously at the time of diagnosis of aplastic anemia, or prior to aplastic anemia or later in course of aplastic anemia. So that's that common, the clone, especially in the idiopathic types of aplastic anemias. So what happens there is that there is a protein which does not have its own anchor to anchor itself in the cell membrane, and so it utilizes something called the GPI. It attaches to the GPI, and the GPI has its anchor which goes inside the cell membrane, and that is how this protein, the GPI anchor proteins, they remain on the surface of a cell membrane. So if the GPI is mutated, and the mutation lies in the X chromosome short arm of the PIGA gene, and if it is mutated, then you will not have this anchor on the surface, and you will not have this protein also on the surface. So there are many proteins which are actually anchored with GPI on the cell membrane. And so if the anchor is missing, you will see that the protein itself is missing. So in RBC, the protein which is missing is generally CD55 or 59, right, which prevents complement-mediated hemolysis of the RBCs, right? So if it's a clone, PNH clone or PNH RBCs, they will lack 59 or 55, and there might be ongoing complement-mediated hemolysis of this patient. Right. So when we diagnose, flow cytometry is most common way and gold standard way presently to diagnose. You can have an antibody against such proteins which are present on the various hematopoietic cells. For RBC, I might have anti-CD59. For neutrophils, you might have CD157 or maybe CD24. Or you can also use something called FLAIR, which directly binds to GPI, just like an antibody against GPI. So what is FLAIR? FLAIR is actually a protein called aerolysin, which you obtain from Aeromonas hydrophilia. It's a mutated protein, commercially mutated there, so that it does not cause lysis of the cell. Otherwise, normally an aerolysin protein from this organism can cause lysis of RBC. So once it is mutated, it will bind to FLAIR, but it will not cause lysis of the cell. And it is conjugated to a fluorescence dye, so you can use it on flow cytometry, right? So once we use it in flow, I will not go into details. This is not a session for flow cytometry, but because it's a very important test for diagnosis of PNH, I'll just skip, sort of breeze through it. So this is what is gating of CD45 positive cells, which mean you have gated all leukocytes, CD45 positive leukocytes, and out of this, you actually gate two lineages, separate out two lineages. One is neutrophils, which we gate on CD15. CD15 is not GPI linked, so it will not be decreased in PNH patients. So you gate on CD15 positive cells, and you are basically looking into neutrophils. So I put this CD15 positive neutrophils in the next plot, and some of these are missing CD24 and flare, the red ones. And some of these are expressing CD24 and flare, which are the normal neutrophils. So in this case, 73% or nearly 74% of neutrophils are not expressing CD24 and flare. The monocytes are gated on 64 and plotted here. And some of the monocytes, rather large chunk of monocytes, 89%, are not expressing CD14, which is a GPI linked protein, and are not expressing flare. Some of the neutrophils are normal, and they are expressing both 14 and flare. So there's a large, major clone of PNH neutrophils and a major clone of PNH monocytes in this patient. This is not usual picture in aplastic anemia. So I'll just show a case of aplastic anemia, 25-year-old male with absolutely hypocellular bone marrow, pancytopenia. And you see the clone size here in neutrophils, absence of 24 and absence of flare in just 0.1%, and absence of 14 and flare in just 0.01% of monocytes. That's the usual situation. There's usually a minor clone present or a rare clone present, generally in aplastic anemia. Obviously, it's not that we don't see a major or large clone at times, but generally you see a very minor clone associated with aplastic anemia patients. The previous plot was for RBCs, where RBCs have been gated on 235A expression, that's glycophorin protein expressed on RBCs, and you have checked the CD59 levels. So this is the normal level of 59. This is moderately decreased. This is absolutely absence of CD59. So categorized into type 3, which does not show any expression of CD59, type 2, which show moderate expression of CD59, and type 1, which are normal RBCs. So you have a PNH clone, which is 23% plus 4%, type 3 and type 2. Here also, it's the same patient. This is dot plot, and this is basically density or contour plot. This is histogram. You see absolute absence of CD59. You see a moderate level of CD59, and you see a normal level of CD59. So that's how you diagnose PNH clone using flow cytometry, right? So we leave it here. Okay, so there's something which helps to diagnose PNH if there's no flow. It's sort of a traditional assay, a cytochemistry, which is a leukocyte alkaline phosphatase or neutrophil alkaline phosphatase, which is decreased in PNH neutrophils. Any neutrophil which is a PNH clone will have decreased level of neutrophil alkaline phosphatase. Why? Because this enzyme is also anchored by GPI, so it will be decreased, right? And then any other traditional test anyone knows beyond flow cytometry, which has been used over half a century? Any test? The name of the scientist, the doctor who actually sort of labeled or discovered PNH from US.
Test.
The Ham's test.
Yes, sir.
Ham's test. Good. Right. Very nice. I'm getting answers. Right. So there, it's an acidified serum test where you see lysis in tube 5 and 8 of RBCs, whereas rest of the tubes show nicely preserved RBCs at the bottom. And that indicates that the patient has PNH and antibodies against or complement-mediated lysis of RBCs in tube 5 and 8. So theory you can read, right? I'm just indicating. So if you don't have flow, you can go for a Ham's test also, right? So with this, and aplastic anemia, there are a lot to it, but that's one of the major causes of pancytopenia as far as non-neoplastic conditions is concerned, and you need to diagnose it correctly, right? We go to the second case, and I can entertain questions. You just keep on noting. If you want, you can interrupt me in between, but we can entertain in the end also. But you are all welcome to interrupt me in between. So we go to a second case where this is 55-year-old female. The patient was on treatment for apparently splenic marginal zone lymphoma. We didn't have any papers besides the diagnosis written somewhere for 4 months, and came with generalized weakness. On examination, a patient had marked pallor, no organomegaly at the time of presentation. The CBC showed severe anemia, TLC, which is 2,400 per microliter, and platelets 31,000 per microliter. So there is pancytopenia at the time of presentation, and there was no organomegaly again, and patient was on some chemotherapy for a lymphoma. That's in LOPAR, the peripheral blood smear. You see some cells, anemia, of course, because RBCs, there's a very low density of RBCs there. Lymphocyte, a neutrophil, possibly an NRBC at LOPAR, but I'll go on HYPAR. So somebody can actually describe that. Bhagyashri, if you are in, can you describe what kind of cell this is? Or maybe this one, this one. Lakshinder. Okay, I don't get any input. Ismail? Ismail was around. Uncleared RBC
I think
is uncleared RBC or nucleated RBC. Yes, good. So I get answers for Pushpanjali also and Mandeep also. Somebody is active there. Nice to see. Definitely. So this is a nucleated, yes, correct. This is nucleated red blood cell. This one looking like a plasma cell, even Golgi zone, but I tell you, this is also nucleated red blood cell. Sometimes they can confuse, and yeah, little opened up chromatin there, quite deep blue. So we have circulating a nucleated red cell. Yes, Mandeep says, could it be leukoerythroblastic picture? At least there is erythroblastosis there. Whether it's leukoerythroblastic picture, you need to have immature leukocytes circulating in the peripheral blood. So yes, you have a partial evidence there. RBCs, see if that's a nucleated red cell, fairly mature appearing, then some of these are fairly large. And some of these are normal looking. You can always compare with a mature lymphocyte. I don't have in this picture, but some of them are looking larger. Some of these are teardrop cells. Some of them are slightly bluish in texture. So these are polychromatophils. They represent the reticulocytes. You have reticulocytes here and nucleated red cells. So a lymphocyte there. It's not exactly a nice mature lymphocyte, some convolutions there, but still comparable. It's not a larger reactive lymphocyte. So if I compare with the nucleus of around 8 microns, you see they are large cells. They are macroovalocytes, macroovalocytes, macrocytes, macrocyte, a macrocyte, somewhat normal looking cells also. So we have RBCs which are macrocytes or macroovalocytes there. Okay. The counts do show some myelocytes I don't have in photograph, metamyelocytes. So correct for Dr. Mandeep to say that this is leukoerythroblastic picture. You have NRBCs and you have circulating myelocytes. So this is a leukoerythroblastic picture in presence of pancytopenia. So that's not a very good sign, I tell you. Whenever you see a leukoerythroblastic picture, whether it's pancytopenia or not, it's not good. But especially when the TLC is low and still you see immature cells in circulation, you need to be very cautious, especially for malignancies at least, infiltrating in bone marrow. Sorry. Another photograph. Anybody? You see a neutrophil there, but something conspicuous about the neutrophil. Janvi? Something about the lobes. Oh, there's another one there in the
It's
inset.
a hypersegmented neutrophil.
Perfect. So that's, you see there, you see if you count the lobes, 1, 2, 3, 4, 5, 6, 7, maybe a small one there, but at least 7 and 1, 2, 3, 4, 5, 6 at least. So that's definite hypersegmented neutrophils in the circulation. You have macrocytes, macrovalocytes, some teardrops, hypersegmented neutrophils, and you're looking into what peripheral blood smear, Janvi? With that findings put together,
The
macrocytes, megaloblastic. Okay.
Megaloblastic anemia.
Yeah. Yeah, I'll stick to a macrocytic overall picture, but since you have HSPs also, it might indicate a megaloblastic marrow. There's a soft pointer, there's a pointer there, but till the time you are into peripheral blood, you possibly limit yourself as finding as a macrocytic overall peripheral blood picture. Macrocytosis might have causes beyond megaloblastosis also. But once you start getting HSPs frequent, you are obviously pointing towards a marrow, which might be megaloblastic. What is this cell? Janvi again. You see some punctured blue dots there?
It's
Eh,
Felix stippling in the
Perfect.
RBC.
Perfect. You see basophilic stippling in the RBCs. Exactly. So again, macrovelocytes, a neutrophil, which is sort of normal lobations there, but looking a little odd. Large cells there, teardrops and basophilic stippling also. Right. So these are the findings. RBCs show moderate anisopoikilocytosis, macrocytes, macrovelocytes, some normocytic, normochromic cells, maybe a few microcytes also, some teardrops. Platelets are markedly reduced. You see hypersegmented polymorphs. The MCV here was 104. Obviously, it is matching with the findings in the smear. MCH, MCHC does not give me too much information. RAW, of course, is going with the moderate anisopoikilocytosis. Reticulocyte count is, although polychromatophils were seen, but overall it is still maybe in the normal limits. For anemia, for the degree of anemia, it's on the lower side if you correct it. And you have a female who's 55 years with a leukoerythroblastic picture and pancytopenia. We go ahead with the bone marrow. So for 55 years, this is definitely a very hypercellular packed particle. There are very cellular looking trails there, right? No problem. A 10x photograph is showing fairly cellular trails, and you see mostly the cells. Okay, we go in hyper, and most of the cells are anybody? Pushpanjali, if you could recognize what kinds of cells these are. Arpan or Ismail? Rather, all of these cells, yes, good. I'm getting answers from Pushpanjali. I'm getting answer from Arpan also, and more people. Erythroid, perfect. So they are all erythroid precursors, right? And they are in varying stages. This one, nucleus is fairly clumped and the hemoglobin is fairly, hemoglobinized, quite like the reticulocyte little amphophilia. And just that it is bilobed and dysplastic. Otherwise, the chromata is looking good. Most of the others are fairly large and fairly opened up chromatin. And you see more, more bluer and the precursor, the earlier stages of erythroblast. If you see a normal marrow, you generally see the maturer forms are forming the majority of the erythroid precursors, probably 40-60% of the cells, maybe more, amongst the erythroid precursors are the late stages. The intermediate stage probably constitute 20% or somewhere around that is just a little subjective percentage there, and the very early forms are just 5 to 10%. So here you see the blue, dark blue early forms are forming a large proportion, which also means there possibly is a maturation arrest in the erythroid series. Excuse me. The another field there, and you see, again, a lot of erythroid cells. You see just a neutrophil here, some myelocytes here, a little, early myeloid precursor, a promyelo or early form there. And rest of the cells are all, erythroid precursors and early erythroid precursors. Even the late ones, that dark clump chromatin is not seen. So that indicates a erythroid hyperplasia in the bone marrow overall with megaloblastosis, right? So we are definitely looking into, you see the erythroid counts in the differential, 73% of the marrow cells are erythroid. That's a large chunk, which means a reversal of myeloid is to erythroid ratio. And most of these are looking fairly megaloblastic. So it's probably moderate or moderate to severe megaloblastosis in the marrow. That's the Trephine biopsy. It's packed for 55 years. Hypercellular, whereas you should have these adipose tissue reaching 50 to 60% of the component of the marrow. Here, the adipose tissue is just around 10%, and 90% of the marrow spaces is constituting of hematopoietic cells, which means it is markedly hypercellular marrow for 55 years. If I go directly into hyper, you see these erythroid cells. So, I've probably not asked question here. Sometimes in marrow, it's difficult to recognize, but I can take 30 seconds here for the morphology. The maturer erythroid cells are ink dot black, right? They are always jet black, absolutely, the maturer forms. And if the fixation is correct, you will see a perinuclear halo. That's an artifact produced by a good fixation there. a perinuclear halo, and then you see the cytoplasm, which is hemoglobinized here in the maturer forms, right? And if you see an RBC there, this distorted RBC or something like that, and the eosinophilic cytoplasm, the cytoplasm quite looks like that of erythroid precursors. The early erythroid precursors are a little difficult to identify amongst myeloid precursors versus erythroid precursors, but there are certain subtle signs. One important sign is the eosinophilic nucleolus, which many times you will see is elongated and it is tethering to the nuclear membrane. So it's a good sign, but remember in a histopathological section, you might not get this orientation in most of these cells. You might cut through transfers, then you will get the nucleolus like this. So that elongated orientation might be in some of these cells. So if you see these cells, the neighboring cells are likely to also be erythroid because the erythroids, they exist as a colony, right? So there's subtle, soft pointers towards erythroid lineage of obviously the cytoplasm, which will be amorphous or fine looking rather than, the granular looking texture of myeloid precursors. So that also a fluffy, non-granular cytoplasm of the erythroid precursor, but that might be tough at times. Right? So more erythroid colonies, a lot of erythroid cells, some mature forms, some immature forms. Not all of them have those elongated nucleoli, but some of them, if they are correctly oriented, will show you the elongated nucleus. And these are erythroid colonies. And sometimes, the biopsy might look very dangerous. It is packed with erythroid cells, immature cells, and it will just look like any leukemia, right? And you need to know your morphology there and correlate with cytomorphology for these cells, then these are erythroid precursors. Obviously, so this becomes, that's for Winthrop, a normal maturation from the early normoblast to the intermediate normoblast to the late normoblast, whereas megaloblastic cells will not have that ink dot jet chromatin. It will have opened up chromatin, whereas the cell is hemoglobinized, right? Even the early looking cell is absolutely seal-like chromatin, very opened up. So, that's the megaloblastic cell for you. Excuse me. So those are the usual findings in peripheral blood macrocytosis, oval macrocytes, teardrops, neutrophil hypersegmentations. I have not shown you oval jolly bodies in this patient, but I do have a photograph of that, not from that patient. And in the bone marrow, you might see his hypercellular erythroid hyperplasia, megaloblastic erythropoiesis, death erythropoiesis might be seen at times. Excuse me, I need a sip of water. Right. That's important feature again. I've not shown you in my photographs. There was probably one of them in one of the slides. Joint metamyelosis. That's also a sign of, megaloblastosis. The deficiency of B12 may not affect, does not only affect erythroid, it affects any cell of the body which is proliferating, right? From the interstitial lining to, pap smear, if you see, to all of these hematopoietic cells, which are, so joint metamyelosis is another sign of megaloblastosis. Increased histiocytes because there is cell death. It is ineffective erythropoiesis, ineffective hematopoiesis going on. There are a lot of cells trying to produce hematopoietic cells because there is pancytopenia. And the histiocytes are there because there's a lot of cell death. They have to do their job and eat up the cells. That's Howell Jolly body for you. And what's Howell Jolly body? Anyone? What is the constituent of this Howell Jolly body? It's basically a nuclear remnant, right? So that's a nuclear remnant for you in circulation. Generally, an active spleen will RNA. No, it's also DNA. But you're not absolutely wrong. So basically a nuclear fragment. And if the spleen is active, it usually pinches this off. In asplenia or hyposplenia or absence of spleen, you will see normally also see oval jolly bodies coming out. And obviously, if there's a lot of turnover in say in megaloblastosis, you will see oval jolly bodies. That's oval jolly body. And what's that? In the RBC, a ring, pink purple colored ring. Anyone that's rarely seen in megaloblastosis and some other erythropoietic conditions. A cabo ring, right? Absolutely. Good, excellent. Right. And what are the constituents of caboring? Okay, that might be a little tough. It's basically a mitotic spindle which is not dissolved. So that forms the caboring because there are a lot of dyshistopoiesis and all kinds of proliferations going on, and the mitotic spindle does not, the microtubules does not disappear, and they form a caboring. Right? So you have a larger size cells in megaloblast as open sieve-like chromatin. Dyshistopoiesis may be present, mitosis is increased. There's nuclear-cytoplasmic asynchrony or dissociation. There might be hemoglobinization, but the nucleus is not maturing. Nucleus is still opened up. Obviously, there is opened up chromatin. So that's how megaloblast is there. So now we have ineffective hematopoiesis in form of megaloblastosis. Can there be other causes, other differentials? Okay. So before that, a theory which again I'll not like to go into details, but most common causes is B12 deficiency and folate deficiency. B12, there can be nutritional and absorptional defects. A vegan diet, of course, B12 is mostly available from the non-vegetarian diet. So you need to look into that. Absorption problems from stomach, absorption problems in the intestine, celiac disease, tropical sprue, fish tip worm, and other causes. Drugs, some drugs which can cause, B12 deficiency. We come to folate again, nutritional deficiencies, increased, requirements, especially in growth stages like infancy, pregnancy, malabsorption like tropical sprue gluten where the folate is not absorbed. Some drugs, methotrexates, pyrimethamine, alcohols, which can cause absorption or, metabolism problems of folate. So that's just, basic causes which you look into when you are approaching or trying to diagnose the cause and reasons for any differential diagnosis. For this picture, again, it's quite classical, but sometimes, some neoplastic conditions like myelodysplastic syndrome and, the erythroleukemia can look like or mimic megaloblastosis, or severe megaloblastosis can mimic these conditions. So you need to rule out these neoplastic conditions where there is a lot of erythroid hyperplasia and maybe megaloblastosis. Uh, Generally, there is a lot of dysplasias in most of the other lineages in the MDS also, and especially in erythroleukemia, you'll see dysplasias in megakaryocytes, you'll see a lot of dysplasias in erythroid lineage, and obviously erythroid lineage in erythroleukemia has mostly immature cells. 80% of these cells, erythroid cells, will be early erythroblast. And obviously you work up more. For, you can give a trial of B12 folate injectables or something, and if patient already has received, blood transfusions or these supplements, and not responded, then you might not be looking into nutritional deficiencies. You might be looking into one of these differential diagnoses. They're important to know because sometimes, you might miss just looking into megaloblastosis there. So we go further. So we have covered two important and common causes of benign or non-neoplastic pancytopenias. One is aplastic anemia, other is severe megaloblastosis. Megaloblastosis, now you have, in our residency time, it was a common condition, and we used to do a lot of marrows. Now it's sort of becoming rarer. At least the marrow for megaloblastosis is becoming rarer. The condition might still exist in the population. Okay, so we go to the next case. It's 49-year-old male presented with fever, loss of appetite, weight loss for last 4 months. So it's sort of a semi-chronic subacute kind of condition. Patient had pallor, splenomegaly 10 centimeters below the left costal margin, and hepatomegaly 6 centimeters below the right costal margin. The patient was diagnosed on bone marrow as MDS, myelodysplastic syndrome, and was referred to PGI. And we have, pancytopenia again. There's a fair amount of cytopenias in the 3-cell lineages. So we looked into the peripheral blood of this patient, 49 years old male. There's some neutrophils. The counts are not too high. RBCs again look, lower density, so anemia is there. The platelets also are few at this par also. I go in, okay, it's a similar par, but what cell is this? Anyone? It's a mononuclear cell, a deep blue cytoplasm. Definitely not neutrophil, not eosinophil. It's basically a reactive looking lymphocyte. Such cells, deep blue cytoplasm, can be seen in viral infections, right? And dengue or EBV or CMVs, these cells can be seen in different shapes and forms. So it's a reactive, circulating reactive lymphocyte, most likely, as far as morphology is concerned. So you have 17% neutrophils, 21% lymphocytes, nothing really grossly abnormal there as far as differential is concerned, but the pancytopenia with organomegalies do exist. We go to marrow. In 49 years, it might be a little more cellular for this age. It's around 50 years, and adipose tissue is a little lower than the overall cellularity. But the best place is, of course, the Trephine biopsy. Aspirate will give you just a suggestion of cellularity at times. And you see cells in the background. That's in the hyper. And we see a lot of myeloid cells, the neutrophils differentiating well. Band forms, the mature neutrophils there, some metamyelos, right? Metamyelos there, myelocytes, again myelocytes. So you see fair number of myeloid precursors. And you see fair number of erythroid precursor looking nicely hemoglobinized and pycnotic dark nucleus. Here. And you also see some plasma cells. 1, 2, 3, maybe a lymphoplasmacytic cell. So those are also becoming little prominent there. And nothing grossly abnormal in the differentials. Neutrophils form the predominant population, which is true for any normal looking marrow. Plasma cells are little borderline high. Below 5% we usually consider normal, so there might be some reaction going on. Erythroids are 30%. And we go in directly in oil. So somebody can describe this large cell, there's something there. Ashrita or Lakshindar have not responded. Bhagyashri is responding. Anybody? What cell is this and what is happening there? A parasite. Okay. Amastigot is the answer, but amastigot itself, LD body is the correct answer. The amastigot form of LD body. The cell I asked is obviously a histiocyte, and you see amastigot forms of LD bodies there inside, filling the macrocyte. So you have splenomegaly, you had fever, subacute condition in this young male, adult male, and you had pancytopenia with sort of a moderate or a moderate spleen, 10 centimeters below costal margin, which means there is an leishmaniasis causing hypersplenism in this case. Another photograph in the oil, and you see those organisms, right? And many of those. And you identify these because you have a nucleus and you have a nice looking kinetoplast in the body of the parasite, right? So that's another histiocyte. The cytoplasmic borders are not seen clearly, but that's in the stomach of the histiocyte as a globular form. Again, a histiocyte with fuzzy looking cytoplasm, a lot of these LD bodies, some lying outside the histiocyte also. Another histiocyte, the nucleus, and some fuzzy cytoplasm with those LD bodies, right? So you have leishmaniasis there. Another cause of pancytopenia, which is basically a splenic sequestration or peripheral destruction of hematopoietic cells. Refined biopsy, do you see organisms, these organisms on refined biopsy? It's a hypercellular looking. That's what happens in a hypersplenism, because marrow is responding to cells which are getting engulfed in spleen or getting destroyed outside, and it is trying to produce hematopoietic cells, and it becomes hypercellular. That's on the hyper. You see histiocytes and those LD bodies inside the histiocytes, right? Many of these, right? So you can locate them in the refined biopsy also. Obviously, formalin shrinks these cells, and the cells don't look that big in formalin fixed tissue sections, but you can localize them. That's the differential diagnosis of LD bodies. Anyone? What is this organism? That's a young female, 28-year-old female, and that's a peripheral blood, was HIV infected. Absolutely good histoplasmosis in peripheral blood, right? And you differentiate it from LD bodies because LD bodies have a nice kinetoplast. They may look similar size, but LD bodies mostly are of exactly same size, around 3 to 4 microns, 2 to 5 microns. Generally 2 to 3 microns. This might vary a little in size, histoplasma, and they are PS positive. nice, the body is PS positive, brightly PS positive, right? Pass puritic acid shift stain, right? Whereas LD bodies are not pass positive. They are either seen on, the nice MGG Gimza stains or on HNE stain, right? So that's the HNE of histoplasmosis. The organisms there, they look quite like LD bodies till the time you can catch an kinetoplast, which is obviously better seen on the cytomorphology. Okay, right. The name is histoplasma capsulatum, and you should know that there is actually no capsule of histoplasma. It's an artifact which it produces and gives a look of a capsule around the histoplasma, right? Okay, so we have hypersplenism, and the causes are many. This is just some of the common causes: cirrhosis, cardiac failure, some infections, malignancies. And then you have basically entered into another cause of pancytopenia, which is splenic sequestration or peripheral destruction. We can see another cause of peripheral destruction also in due course, and you obviously need to evaluate for why there is hypersplenism there. Yeah, so we go to the next case. Any queries you can put in, I'm open to any answers there. This one is 22-year-old male, and we presented with acute febrile illness and diarrhea for 6 days. So acute illness there. Patient carried some reports which told that there is likelihood of splenic abscesses on imaging, and patient had splenomegaly of 4 centimeters below costal margin. CBC again showed cytopenia, rather severe cytopenia overall. 20x, possibly a neutrophil there. RBCs are scattered, low density. There is a circulating myelocyte there, nothing very prominent. Lymphocytes are bordering on the higher side. You see the higher part of neutrophils, they look dirty. There's some granules which are coarser, toxic looking, some vacuolations or some, differential staining there. So practically they are not looking good, and this is how sometimes we describe the toxic looking, neutrophils responding to something. The patient had a short history of fever. Yeah, the neutrophils are likely to respond, right? Marrow is for 22 years is just okay. Good cellularity, maybe normocellular or maybe slightly hypercellular. I'll call this normocellular on aspirate for 22 years. Marrow cells looking quite good. There are all kinds of neutrophils, myeloid series cells. There are, erythroid series of cells there, seen there, and there are lymphocytes. There are some plasma cells, but concentrate on these cells. A histiocyte with something inside, a histiocyte with something inside, a histiocyte with something inside, a histiocyte which is activated, bloated, mota. And generally the histocytes, benign histocytes are, not that fat. The counts do not tell us too much. Neutrophils 25%, usual myeloid precursors, plasma cells not much, erythroids just normal. But you see that histiocyte. So what is happening here? Anyone? Is something in the stomach? And peripolysis is a very nice differential diagnosis which you should know. Generally, it's a phenomena which occurs in megakaryocytes. And peripolysis, this is hemophagocytosis. Somebody calls this HLH, histiocytic lymphohistiocytosis. And that is a syndrome. What I see on marrow is hemophagocytosis. This has RBCs inside the stomach. It has some platelets. It has some debris of cells which has already been eaten up and destroyed. Again, you see a nucleated red cells inside the stomach. Some debris of nucleus, cells which are dying, in process of dying. Possibly a granulocyte which is now in apoptosis. You can see the eosinophilic cytoplasm. Another granulocyte possibly, or some other cell which is in process of dying. So this hemophagocytosis happening. HLH is a syndrome you need to diagnose based on criteria. What I can say is that there is definite significant hemophagocytosis going on. Since there is a pancytopenia, the HLH might be going on, and you need to fulfill the criteria of HLH to diagnose HLH. So marrow, you see another cause where their cells are getting destroyed in spleen or in marrow and in other organs which are histiocyte rich, and that's the peripheral destruction of RBCs or destruction of RBCs. Right? Pearl stain, In this case, it was not really important, but this is a good amount of iron, probably 3 or 4 plus of iron in the particle. But why I show you this? Because the histiocytes are iron loaded there. That's an isolated histiocytes. If I go on hyper, they have the histiocyte, the cytoplasm contains iron. They are shining blue. And what is important is the counter stain for the nucleus, which is nuclear red, is showing multiple nucleus in the same cell of histiocyte. So, which also, sometimes Paul stain in this case helps as a surrogate to identify hemophagocytosis. Each cell is just bloated up with multiple other cells, filling up the cytoplasm. So it's just to show, a histiocyte which contains a lot of iron. It is helping us to identifying other cells which are shining, with the nuclear red stain, the neutral red stain in the cytoplasm of the. So that's hemophagocytosis for you. The biopsy, it might be difficult to identify at times in biopsies, but you could see those pale areas are basically histiocytes. Sometimes it does give a starry appearance of buckets when there are too many, and sometimes in aggregates also. So in higher power, you see this fuzzy cell, a histiocyte, some cells inside, a fuzzy cell there, bubbly cytoplasm, vacuolated, or somewhat, fuzzy cytoplasm there. Another one, some RBCs or some cells inside that histiocyte. So it might be difficult. Sometimes, the PAS stain, the periodic acid stain might help because it gives the pale look of the histiocyte and cells inside. Some cellular debris might stain PS positive, others might stain with the hematoxylin, and you see those cells. Sometimes Merson's trichomes also helps. The RBCs and the nucleated red cell precursors shine orange with the histiocyte shining pale. So these are cells. That's the criteria of HLH, and you to fulfill. I'll go away with this theory part. You can always read that, but there are criteria which you need to fulfill. That's an older criteria of 2004, probably 10 years back. The society changed, probably sort of removed this, which assay is not available in most of the labs. The rest of the criteria remain same to date. So HLH can be primary, secondary because of infections, malignancies, autoimmunity. These are not comprehensive. And primary because of genetic disorders, genetic mutations in, genes which influence cytotoxic T cells or NK cells or inflammasomes. So those are the genes, perforin, UNC, syntaxin, and some others, and for inflammasome. So the genes, number of genes keep on increasing. These are just some examples for you for the primary HLH and for the secondary. So we are off with the three major chunk of causes of pancytopenia: bone marrow failure, ineffective hematopoiesis, megaloblastosis there, splenic sequestration or peripheral destruction, and we go to the last cause, which is bone marrow infiltration. And the infiltration, of course, the most common causes, the commoner causes you look for or hunt for is the malignancies, which might be solid malignancies or which might be hematopoietic malignancies. But I'm not dealing with that. Just for an example, the hairy cells, fried egg appearance. So these are common causes of pancytopenia, or the LGL leukemias. They might have subtle presence in the bone marrow, but they have cytokines which produce cytopenias, and obviously the solid malignancies. But I leave it there. I don't encroach upon neoplastic disorders. And let's see if there's something non-neoplastic which can be infiltrating in bone marrow and causing pancytopenia. So that's 36-year-old male. Patient is post-renal transplant on azathioprine tacrolimus, so triple drug therapy there, which is commonly continued post-renal transplant for a long time. The dose might be manipulated, and the patient had fever for 2 months and worsening cytopenias. Right. Severe cytopenias. Platelet count may be moderately reduced, 82,000, very severe leukopenia, and a moderate or a severe anemia there. Nothing grossly there, some two neutrophils. Again, a neutrophil which is looking like, somewhat responding fuzzy. Granules are not too much, some vacuolations, or maybe a, stored sample, something like that. It's not healthy looking neutrophil. RBCs don't look too bad. They are normocytic, normochromic. Some are, crenated, and some are little microcytic RBCs, but not a lot of anisopoikilocytosis. Platelets are markedly reduced. Okay, so you have this cell, an immature circulating myeloid series cells, a myelocyte there in circulation, a nucleated red cell in circulation, right? platelets are markedly reduced. So you have a leukoerythroblastic picture with occasional NRBC, some myelocytes, a few in circulation. Yeah. And at a very low TLC, you start seeing leukoerythroblastic picture, which means there is something grossly wrong in bone marrow. That's the picture, right? Leukoerythroblastosis. We go to bone marrow. For 36 years, this might be, slightly lower on cellularity, more of fat around, but somewhere mildly hypocellular to normocellular on aspirate. You see megakaryocytes on this bar also. Good megakaryocytes. Although the platelet counts were low, you see healthy megakaryocytes and other cells. Yes. Early pro-erythroblast, early erythroblast, late erythroblast, dysplastic erythroblast, myeloid series of cells. The neutrophils you see are low in numbers. There's more of myelocytes, some promyelocytes, a metamyelocyte, right? So neutrophils, which usually form 1/3 of the myeloid series of cells, are lower in numbers. A plasma cell there. Nice HOF, blue cytoplasm, eccentric nucleus. Again, a lot of myelocytes and promyelocytes. A histiocyte there with some, pigment or debris. Erythroid cells, right? So you have myeloid cells, but the neutrophils are low in numbers. Here in counts, it's 90%, 19%. I have not taken photographs from those areas where you could still see, but they're still lower in numbers. 24% myelocytes, so increased. Yeah, rest is all looking normal. Marrow for young person, it's slightly on the lower side of cellularity, definitely. But you see something odd. There's a nodule there which is bubbly and, vacuolated, and something odd there in 36 years. And a small nodule there, paratrabecular, something odd. Otherwise, here you see normal, interstitially distributed hematopoietic cells. But in these two images, there is something wrong there. These areas are just normal, and the hematopoietic cells are just going interstitially amongst the the adipose tissue. Yeah. So we can go on hyper. Again, some vacuolations there, a nodule there. And a more hyper, you see something there. Anyone? What this could be? Some structures. I'm waiting for some replies. Any guesses? Fungus. Good. Broad category. Good for exam. You're not committing, and that's good. CMV, CMV, the virus you cannot see on light microscopy, but you can see inclusions, mostly in form of giant nucleus. So the nucleus is packed with CMV. It becomes a very big cell with a very large nucleus. These are in the cytoplasm. So correct this as fungus. What kind of fungus? Oh, in oil. Histoplasma, you see a nice capsule there. So something which is capsulated with the body. Histoplasma is generally not that big also and vary in size. You see the small sized, non-capsulated, moderate size, small size, large size. Cryptococcus is correct. Absolutely correct. So we are dealing with a fungus forming nodules you see at the low part. Histocytic nodules, the histiocytes, obviously, they are in syncytium, you can't outline. Their stomach is filled with these organisms, so you can't really identify them correctly, but there's a nodule of histiocytes containing the fungus. And what can you do to establish some cytochemistry? The body stains with pus nicely, paradigm shifts, and the capsule stains with any stain. India ink is a negative stain. CSF is the best. The negative shadows indicates some positive. Mucicarmine, correct. Any other? Correct. Okay, so that's paradigm acid shift stain for you. The body stains nicely, magenta pink, and that's Alcian blue for you. The capsule stains blue. You can use mucicarmine also, and you can use other fungal dyes also, but Alcian blue here I'm showing you. That's PS with Alcian blue together, so the body is pink and the capsule is blue. So the infiltration completely and causing pancytopenia. Cryptococcosis. Can there be other things? For bone marrow infiltrations, yes, of course. Langerhans cells, granulomas. So you can have tuberculosis, disseminated tuberculosis encroaching about marrow spaces and causing cytopenias. It's not very uncommon to see that in our country. Children, storage disorders. So I'm showing you all these cases from routine reporting there on HNE, on cytomorphology, Niemann-Pick, vacuolated cells. So these are just examples. What's that? A lot of fibrosis, paratrabecular fibrosis with osteoblastic cells rimming it, some osteoclasts eating up, dense fibrosis eating up marrow spaces, hyperparathyroidism, right? So you can have these conditions, non-neoplastic, which can present as cytopenias at times. These are rarer disorders, but besides neoplastic conditions which encroach and infiltrate the marrow, infections, tuberculosis, fibrosis because of other causes, storage disorders, these are disorders which are non-neoplastic for you. Just some studies before I end, literature which shows most common causes, aplastic anemia, megaloblastosis, aplastic anemia, megaloblastosis, hyposplenia. So you see, it's most of the time 4 times megaloblastosis, but this is from 2019, not too much, in the past. Fairly okay, recent article. Another study in 2020. Commonest cause, aplastic, megaloblastic, aplastic, megaloblastic, megaloblastic, aplastic, hypoplastic, aplastic. So you see, that's the distribution amongst the non-neoplastic conditions of pancytopenia in India. Those are Indian studies. So you can't get rid of diagnosing these entities, and you need to know and diagnose them. So for approach, you need clinical inputs, definitely. Those are basic clinical inputs which you need to know before you go ahead. Hematopathology cannot be practiced in isolation. It's a little different from histopathology. Obviously, there also you need to know inputs, but some diagnoses are so classical you may not need clinical history. For hematopathology, it is must to get your clinical inputs correct. Otherwise, you will be making something else out of something else. Similarly, for clinicians also, it's a totally dependent branch to each other before you make a correct diagnosis. So clinical inputs, investigations, I'll just put some examples. If it's fever scenario, there are some investigations. These are not comprehensive again. HLH, these are the criterias which investigation metastasis, just go with certain investigation which you need to know or you need to do. Obviously, you go into peripheral blood smear with pancytopenia. You look into certain things. You are looking into megaloblastosis when you're looking into macrocytosis or aplastic anemia or MDS. If it's leukoerythroblastic, you are trying to find into certain conditions which can cause leukoerythroblastosis, some malignancy, infections, fibrosis, splenic sequestration with pancytopenia, HLH, PNH. These are disorders which can cause pancytopenia in peripheral blood. Again, a mixture of some neoplastic disorders and when pancytopenia can occur. When you go ahead for bone marrow in this condition, you can have a hypocellular, hypercellular marrow. In hypercellularity, of course, megaloblastosis, some infiltrations, hypersplenism. I leave neoplasia for now. You go ahead with, B12 folate levels and other things. You go ahead for causes of hypersplenism. Right, I leave that. For hypocellularity, aplastic anemia, of course, acquired or inherited. Look into the causes. Inherited, you need some clinical inputs. You need to do these tests, chromosomal breakage studies. NGS presently is probably become quite necessary for correct diagnosis of inherited bone marrow failure. If the cellularity is variable, PNH is one cause where you can have hypocellular marrow, normocellular marrow, hypercellular marrow. All of these can be present. And you, of course, go for flare. Variable cellularity, myelofibrosis, which can have various causes, malignant as well as non-malignant. HLH, variable cellularity again. In early HLH, the marrow can be cellular. In late, the cytokines, they do not allow marrow to regenerate, and there might be collapse of hematopoietic cells there. Primary, secondary, and we have already discussed that. So I leave it there. I'm open to questions. Let Rishi come in because we need to know how a clinician looks into pancytopenia and what they want from hematopathologists when we are looking into it. And he can, probably given his pulse for us, and you can ask questions. Yeah. Thank you. Okay, so I've overshooten the time. Is Rishi around? Hi, Dr. Rishi.
Yes, I'm very much here, and it was interesting and very informative for me as well to look
Okay.
at the exhaustive pathology differentials of illnesses presenting with pancytopenia.
Right. Thank you. Good.
What is important to realize is that infectious diseases and other illnesses other than immune aplastic anemia are far more common as compared to acquired aplastic anemia and inherited bone marrow failure syndromes. It is because we often sitting in institutes see patients with referral bias. So we think that aplastic anemia is common, but it is least common. When I see a patient of pancytopenia in clinic, other differentials are more on top of my head, like patients with malignancy. Acute promyelocytic leukemia is notorious for presenting with low blood counts, and it is a diagnosis that has to be made as early as possible, as patients are at 30% of the patients are at risk of early deaths if left untreated. Then autoimmune, like HLH has been discussed. Lupus is a rheumatological disease that often presents with cytopenias. Then infections, we have discussed viruses and mycobacteria, metabolic illnesses. So that is with my comment regarding the approach to diagnosis. The other thing is that I want the MD residents to know that acquired aplastic anemia is more of a disease of the Asia, Oriental countries. India has far more common incidence of acquired or immune-mediated aplastic anemia as compared to the West, and the exact reason for this is not known. At AIMS, we see around 300 to 400 new patients every year.
Right. Interesting to know, Rishi. Right. Okay. Yeah.
And it is important to differentiate between acquired and inherited bone marrow failure syndrome because the treatment approaches are different. Acquired aplastic anemia is treated with immune suppression, and inherited bone marrow failure syndromes they do not get to be treated with immune suppression. The only cure is bone marrow transplantation. So if there are any questions, then probably we can discuss and cover more ground.
So one question is, should we see only intact cells or even debris of cells can be considered in hemophagocytosis?
Okay, so that's a good question actually, because there are recent papers on this for as far as diagnosing HLH correctly is concerned. If I go by one or two papers who have indicated that intact WBC is the most important cell for diagnosis of HLH as far as hematopathology is concerned, then those are one or two papers who sort of confidently put in that way, probably because it relates clinically also to presence of HLH, whereas just enucleated cell RBCs or platelets or some debris may not indicate phagocytosis correctly. But these are one or two papers, and it's not universally followed. Sometimes you get evidences of good amount of hemophagocytosis just based on some RBCs, platelets, and maybe some NRBCs lying inside, and the patient will also be symptomatic. So I'm not very sure whether we go ahead and sort of accept that literature available as only intact cell indicates or not. But yes, some authors and some groups have felt that and written that. We diagnose HLH even without a definite intact cell, but you need to have at least some nuclear remnants and nuclear debris for a good correlation of phagocytosis, right?
And it is
Uh,
important to note that many of the infections that have been discussed can also present with HLH, with pancytopenias, like tuberculosis or viral infections. They can lead they can cause hemophagocytic lymphohistiocytosis and present with cytopenias. So these patients are generally very sick at the time of presentation.
Right, exactly. Yeah, very nicely pointed out. So rather many of even the LD bodies we saw, there have been patients which have presented a lot of hemophagocytosis with tuberculosis. We've seen that, and rather most of these can present with hemophagocytosis, whatever infections have sort of shown.
With regards to acquired aplastic anemia, once we have done a marrow examination, seen that it is empty, replaced with fat, and we sign it out as a possibility of aplastic anemia, then the further tests that need to be done apart from flow cytometry for PNH, because PNH is important because 60% of the acquired aplastic anemia patients will have a detectable PNH clone. And the very fact that a PNH clone is detectable is strongly suggestive that it is an acquired aplastic anemia rather than an inherited bone marrow failure syndrome, like Fanconi presenting with pancytopenia. The other tests that are generally that are part of the guidelines but are not freely available in India, but they need to be done upfront. And for the sake of completion, I'm just mentioning them, is our telomere length estimation because of telomere biology diseases that present with low blood counts. Then lymphocyte subset analysis needs to be done because they suggest GATA2 deficiency, and NGS, myeloid gene panel needs to be done because
Right,
to look at the clonal structure of the disease.
right, right. Thank you, Rishi. That's good. Right. True. Obviously, we have not touched neoplastic. There are a lot of neoplastic ones, so somebody in the course of lectures might touch those. It's important. Like Rishi pointed out, APMS is one of the probably most important diagnoses of pancytopenia and rapidly to be made. So, since this was non-neoplastic, but we need to have that picture also in mind. It's just for lecture that we are putting as non-neoplastic and neoplastic. In a clinical scenario, when you're sitting in OPD, you have to make a diagnosis irrespective of what it becomes. So you need to know and be aware of these diagnoses also.
Another question is how to differentiate between megaloblastic hyperplasia and erythroleukemia on morphology.
That's not always easy, but erythroleukemia now in WHO has a very specific definition. Morphology per se, if we limit ourselves to morphology, there are limitations, but I can tell you soft pointers. One, more than 80% of cells must be erythroids. That is one thing. Out of those, majority should be early erythroids, which means pro-erythroblasts. So this condition happens in megaloblastosis only in a very, very severe megaloblastosis condition, which is not common. Generally, megaloblastosis are either mild to moderate, and moderates can also cause symptomatic pancytopenias. So you go into above 80% of erythroid linear cells in bone marrow, and out of erythroids, majority above 80% should be, or somewhere near should be, the early erythroblast. And that means there is hardly any maturation occurring. The dysplasias are striking, and the dysplasia is not limited to erythroid lineage. It is seen in myeloid also, and very conspicuously seen in megakaryocytes. Generally, the megakaryocytes are also increased in numbers, and they are lobe separated, they are hypolobulated. There's good dysplasia in megakaryocytic lineage also, right? So these are soft pointers towards morphological aspect of looking into whether it's erythroleukemia or not. But remember, never go into isolation because there can be overlaps in very severe megaloblastosis. But just these are soft pointers where you need to say that whether I should work up for actually for erythroleukemia further or not, right? And of course, look into history. If the patient has been given, enough supplements, hematinics, especially parenteral. There might be absorption issues, and if there is IV, IMs, or blood transfusion per se. So if there are 1 or 2 or 3 blood transfusions, you already given dosage of iron, B12, folate, IV per se to the patient. If the patient has not responded in any way, especially with a higher reticulocyte count, as early as rising 4th, 5th day, you will start seeing rise with giving the supplements. It's not responding to the extent it should. You're probably looking into something else, and you can go ahead with workups. But morphologically, I think those are the pointers. Majority being erythroids, dysplasias, right?
Yes, how to differentiate LD body from histoplasma on section?
Then
Not
it
bone
becomes
marrow.
very difficult. Yeah. Section, it can be very difficult, antibodies versus histoplasma. They both are intracellular most of the times. They most look similar. Generally, there might be a pseudo space around the histoplasma, but that can may be seen because of artifacts in LD bodies also. Kinetoplast, if you can identify, if the section is good, then you will be able to identify kinetoplast in some of the LD bodies depending on the orientation where they have been cut. So that's the only good sign. Also, LD bodies are quite uniform in their size. They don't vary too much. Histoplasma does vary, although it does not vary as much as Cryptococcus. Cryptococcus can go from very small to very large. Histoplasma does vary in size to some extent. So these are soft pointers. You can do a PS stain. A periodic acid stain is as simple as that. LD bodies are negative. Histoplasma is brightly positive. That will solve the issue. So morphological indicators I have told, if kinetoplast you can identify depending on how section is done, helps you. It's a good pointer. Otherwise, do a PST, right?
Thank you, sir. How to differentiate a reactive lymphocyte from a blast?
Okay, that's a general question. Again,
Sound is gone. Hello, sir. Manu, sir. You're not audible. Sir, we cannot hear you. Yeah. So we cannot hear you. Hello, sir. Rishi, sir. Manu Putesh, sir?
No, I am very much here, but I
Um,
I cannot answer the lymphocyte question. It's been almost a decade since I looked down the microscope.
Manu sir is compliment. Sir is not at all audible. I don't know what happened. Uh, so can you take this? Are there any phenotypic abnormality seen in cases of aplastic anemia by flow cytometry? Non.
No, 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 no.
No.
So phenotypic abnormalities. So people have actually, as a part of research, have looked at the T cell clones, and V beta flow cytometry is done to say that okay, there is a clonal T cell population in acquired aplastic anemia that is autoreactive, so it targets the hematopoietic stem cells. Apart from that, but nothing with regards to day-to-day diagnosis.
Uh, And how to comment a marrow is diluted with the peripheral blood? Any criteria? But Manu sir is not. Shall we wait for 5 more minutes? Sir, maybe the internet has gone, so may come back.